Presentation on congestive heart failure by Leilani Castleman. First, let's review some basic anatomy of the heart. Remember that the venous blood is pumped in through the inferior and superior vena cava into the right atrium, and that goes to the right ventricle, and the right ventricles pump out the pulmonary valve and pulmonary artery to the lungs. The blood gets reoxygenated and comes back in through the pulmonary veins into the left atrium, down to the left ventricle, and then it is pumped out through the aorta and to the rest of the body. But remember, this is all occurring simultaneously, and that is the cardiac cycle. So diastole is when the right and the left atria are relaxed as blood fills from the superior and inferior vena cava to the right and to the right atrium and from the pulmonary veins into the left atrium. So this is basically the resting phase of the heart. Then increasing pressure on each side causes the AV valves to open up and the ventricles on each side begin to fill up. And then systole begins when the atria contract and empty as the ventricles become full. When the ventricles begin to contract, that pressure closes those AV valves and the atria are relaxed. The ventricles contract with increased pressure and the aortic and pulmonary valves open up. Blood is ejected into the aorta and the pulmonary artery. And then the ventricles empty and relax and the aortic and pulmonary valves close. So remember, the right ventricle is pumping blood out of the pulmonary artery into the lungs, and the reoxygenated blood is returning through the pulmonary veins into the left atrium. The left ventricles are pumping blood through the aorta out to the systemic circulation and then returning to the right atrium via the superior and inferior vena cava. Having an understanding of this process helps you understand congestive heart failure. So on this slide, I've included a link to a YouTube video that shows you a nice visual of how that cardiac cycle is happening all simultaneously. Basically, the same volume of blood is pumped from the right and left sides of the heart during each cycle in a healthy heart. This is important to ensure that blood flow through the systemic and the pulmonary circulation is consistently balanced. When there's congestive heart failure, there are abnormalities in the heart that affect that cardiac cycle. Usually CHF occurs as a result of another condition. Some of these include maybe a previous myocardial infarction or a valve defect. Other conditions that impose increased demands on the heart, such as hypertension or lung diseases, or a combination of problems, can also lead to CHF. Initially, one side of the heart is affected depending on the cause, and that failure leads to a failure of the other side. So here's an example. If a myocardial infarction or essential hypertension is the cause, it will affect the left ventricle first. If pulmonary diseases are the primary issue, it will affect the right ventricle first. Basically, there are two main effects when a heart cannot maintain its pumping capability. First, the cardiac output decreases, resulting in less blood reaching the organs because the affected ventricle cannot pump its load adequately. And the return of that blood to that side is also impaired. That leads us to number two, a backup of congestion occurring on that side and the circulation that's behind that affected ventricle. The outflow of the ventricle is less than the inflow of the blood. So establishing if it's a right-sided or left-sided congestive heart failure initially will help direct treatment to break the cycle and direct appropriate interventions according to the pathophysiology. So let's take a look at right side versus left-sided heart failure and the causes of this. So in right-sided heart failure, it could be caused by infarction of the right ventricle, pulmonary valve stenosis, pulmonary diseases, or cor pulmonale. And the basic effects of this is decreased cardiac output, systemic congestion, edema of the legs and abdomen. So in right-sided heart failure, the right ventricle cannot maintain its output. So less blood proceeds to the left side and to the systemic circulation. That is termed the forward effect of CHF. The backup effect, or congestion, is occurring behind the right ventricle and is apparent in the systemic circulation with increased blood volume and congestion. So you can see if the right ventricle is not pumping correctly, we're going to have that backup. If we go backwards in the heart, that right atrium is backed up, that venous blood flow coming back to the heart, there is backup there too, leaving all the congestion in the body. So signs and symptoms of right-sided heart failure: because of the decreased output, we will see fatigue, weakness, dyspnea, exercise or activity intolerance, cold intolerance. Because of the heart trying to compensate, we see tachycardia and pallor, secondary polycythemia, and daytime oliguria. But because of the backup of volume, we see dependent edema in the feet, hepatomegaly, splenomegaly, ascites, distended neck veins, headache, and a flushed face. Now, in left-sided heart failure, this could be caused from infarction of the left ventricle, aortic valve stenosis, hypertension, hyperthyroidism. And the basic effects when this happens is decreased cardiac output again and pulmonary congestion. So in left-sided heart failure, the left ventricle cannot pump all of its blood to the systemic circulation. So there's a backup behind the left ventricles where blood cannot return to the lungs. Blood cannot return from the lungs to the left side. So that causes congestion in pulmonary circulation. Signs and symptoms of left-sided heart failure include decreased cardiac output. Signs and symptoms from the decreased output are fatigue, weakness, dyspnea, activity intolerance, cold intolerance. And from the compensatory effects, we see tachycardia, pallor, secondary polycythemia, and daytime oliguria. Remember, those are all the same side effects that we saw with the right-sided heart failure. But from the backup effects, we see orthopnea, cough producing white or pink tinged phlegm, shortness of breath, paroxysmal nocturnal dyspnea, hemoptysis, and rouse. So there is a backup or congestion in the pulmonary system. There are various compensation mechanisms that the body tries to do to maintain cardiac output. Unfortunately, those mechanisms often aggravate the condition of heart failure instead of providing assistance. For example, the reduced blood flow into the systemic circulation and thus reduced blood flow to the kidneys leads to an increase in renin and aldosterone secretion. The resulting vasoconstriction and increased blood volume add to that heart's workload. The sympathetic nervous system response also increases the heart rate and the peripheral resistance. So that increased heart rate may decrease the efficiency of the heart pumping and impede filling, as well as increasing work for the heart. The chambers of the heart tend to dilate or enlarge, and the cardiac muscle becomes hypertrophied, or also known as cardiomegaly, with the wall of the ventricle becoming thicker. So this process demands increased blood supply to the myocardium itself, and eventually some myocardial cells die to be replaced with fibrous tissue, and that leads to even less effective pumping of the heart. The risk factors and genetic factors of congestive heart failure, the primary causes of it would be hypertension, coronary artery disease, including myocardial infarction, rheumatic heart disease, congenital heart defects, pulmonary hypertension, cardiomyopathy, either caused from viral or postpartum or substance abuse, hyperthyroidism, valvular disorders like mitral stenosis and myocarditis. Hypertension and coronary artery disease are the primary risk factors for heart failure. And let's not forget that hypertension is a modifiable risk factor that we should be aggressively treating and managing. Long-term treatment of hypertension does reduce the incidence of heart failure by 50%. Other comorbidities such as diabetes, metabolic syndrome, advanced age, tobacco use, and vascular disease also contribute to the development of heart failure. Some other risk factors and genetic factors that are precipitating causes of heart failure include anemia, infection, thyrotoxicosis, hypothyroidism, dysrhythmias, bacterial endocarditis, obstructive sleep apnea, pulmonary embolism, Paget's disease, nutritional deficiencies, and hypervolemia. So precipitating causes often increase the workload of the heart, resulting in an acute condition and decreased heart function. So in our nursing assessments, we need to start with our subjective data from the patient. Starts with the health history. So we need to know, do they have any coronary artery disease, any recent MIs, hypertension, any valvular or congenital heart diseases. Diabetes would play a role, any high cholesterol or hyperlipidemia, renal disease, a thyroid or any lung diseases, any rapid or irregular heart rate that the patient states they may have. Medications, we need to find out, do they take their medications on a regular adherence, especially any heart medications. We need to know if they take any diuretics or estrogens, any steroids, any non-steroidal anti-inflammatory drugs, including over-the-counter drugs and herbal supplements. And then their functional health patterns, their health perception. How do they perceive their health? Do they report fatigue, depression, anxiety? And then their nutritional or metabolic health patterns. What is their usual sodium intake? Do they have complaints of nausea, vomiting, anorexia, stomach bloating, any recent weight gain, or any swelling of the extremities? Their elimination, do they have nocturia? Do they have decreased daytime urine output or even constipation? Then their activity and exercise, we need to know if they are short of breath, dyspnea or orthopnea, or if they have a cough, like a dry productive cough, or do they report any sputum that they're coughing up? Do they have palpitations? Do they ever feel dizzy? Do they ever faint? Their sleep and rest cycles, the number of pillows used for sleeping. And that's pretty indicative of if they have sleep apnea or not. Paroxysmal nocturnal dyspnea. Do they have problems sleeping or breathing at night while they're sleeping or laying down? Any insomnia and any sleep apnea. And maybe you can get a report from their partner if they have snoring or if they stop breathing during their sleep. Then their cognitive, perceptual, any reports of history of chest pain or heaviness, any right upper quadrant pain, abdominal discomfort, any behavioral changes, or any visual changes. The objective data that we are gathering in our nursing assessment first includes the integumentary system. Do they have cool or diaphoretic skin? Any cyanosis present or pallor? Any peripheral edema, which could indicate right-sided heart failure? Their respiratory patterns. Do they have tachypnea? Do they have any crackles, any wheezes, any frothy or blood-tinged sputum? We should pay particular attention to. And then cardiovascular. Do they have tachycardia? Do they have any heart murmurs? Any irregular heart sounds? Any jugular vein distension going on? And then gastrointestinal system. We should be looking at any abdominal distension, especially like ascites. Be looking for hepatosplenomegaly. And then neurologic, we should be looking at, are they restless? Do they have any confusion? Do they have any decreased attention or memory loss? And then we should be looking at possible diagnostic findings. Any altered serum electrolytes, especially sodium and potassium. If there's an increased BUN, creatinine, or liver function tests, increased BNP, chest x-ray that might show cardiomegaly, any or a chest x-ray that would show some pulmonary congestion. Maybe an echocardiogram showing increased chamber size, any decreased wall motion, decreased ejection fracture or normal ejection fracture with evidence of diastolic failure, atrial and ventricular enlargement on an EKG, and any signs and symptoms of decreased saturation of oxygenation should be paid close attention to. In our expected treatment or acute care of heart failure, we need to consider if they have acute decompensated heart failure, which is defined as the sudden onset of signs and symptoms of heart failure, and this requires urgent medical care, or chronic heart failure, which is characterized as a progressive worsening of ventricular function and chronic neurohormonal activation that results in ventricular remodeling. So we'll take a look at both of these. In both of them, though, we do want to treat the underlying cause of the heart failure, whether that be hypertension or some conduction abnormalities. We also want circulatory assist devices like ventricular assist device. We want daily weights to be managing that circulatory overload that's going on. Sodium and possibly even fluid restricted diets. We're especially going to be looking at our ABCs, especially in an acute care and in an emergency. So patients with acute heart failure need continuous monitoring and assessment. If they're unstable, these patients need to be in the ICU. They need to have continuous heart monitoring, continuous O2 saturations, assessment of vital signs and urine output at least every hour. We're going to provide supplemental oxygen to help increase the percentage of oxygen in inspired air. In severe pulmonary edema, the patient may need non-invasive positive pressure ventilation or even intubation and mechanical ventilation. In more stable patients with acute heart failure, they may require hospitalization also, but not need to be in the ICU. So they're often admitted on a telemetry unit or a step-down unit for treatment. We'll be assessing those patients every 4 hours with their vital signs, at least, and pulse oximetry, that they're receiving adequate oxygenation. We're going to be recording their intake and output, their daily weights to evaluate their fluid status. If they have dyspnea, we can place them in a high Fowler's position with the feet horizontal in the bed or dangling at the bedside, because that position helps decrease venous return because of the pooling of the blood in the extremities. Some medications we might be giving with both with any heart failure would be diuretics. And diuretics are the mainstay of treatment in patients with volume overload. So they're going to decrease sodium reabsorption at various sites within the nephrons, thereby enhancing sodium and water loss, getting that fluid off of them. Vasodilators can help by reducing circulating blood volume. ACE inhibitors may help by reducing that renin secretion and vasoconstriction. Digoxin would help by improving cardiac output, improving the contractibility of the heart. Morphine may be a medication used also. Morphine will reduce the preload and afterload of the heart. It helps relieve dyspnea and anxiety caused by the dyspnea. Let's take a look at some patient education. Let's start with primary prevention to avoid the disease in the first place. So currently the emphasis is on aggressively identifying and treating any risk factors for heart failure. So to prevent those risk factors in the first place, let's prevent the modifiable ones. So people need to maintain regular appointments to monitor their blood pressure, monitor their cholesterol, and keep their immunizations current, including their flu shots. Maintain a healthy diet and weight, maintaining a regular exercise regimen, avoiding smoking in the first place and secondhand smoke, and maintaining moderation with alcohol use. A secondary prevention, let's focus on when there are risk factors already, when there is cardiac disease present, but before it has evolved into heart failure. So we want to teach a patient with hypertension or hyperlipidemia ways to manage their blood pressure or cholesterol with drugs, diet, and exercise. Encourage them, again, to get a flu shot and pneumonia vaccines. Patients with valvular disease should be evaluated for valve replacement procedures. Coronary revascularization procedures should be considered in patients with coronary artery disease. Antidysrhythmic drugs or pacemaker therapy is indicated for patients with serious dysrhythmias or conduction disturbances. And again, if they have any cardiac issues, reduction in sodium in their diet, fat intake, smoking cessation, and weight reduction is going to help them prevent their cardiac issues resulting in heart failure. Next, we'll look at tertiary interventions, patient education after the disease is established. Include instructions when teaching the patient and caregiver about the management of heart failure on the following items. Drug therapy. Take each drug as ordered. Develop a system like a pill box to ensure drugs have been taken. Count pulse rate each day before taking drugs if appropriate. Know the limits that your healthcare provider wants for you for your pulse rate. If they're taking digoxin, they need to know if their pulse is below 50 to withhold that medication. Take blood pressure at determined intervals and know your target blood pressure limits. Probably a good idea to keep a log of your blood pressures. Know the signs and symptoms of orthostatic hypotension and how to prevent them. If taking anticoagulants, know the signs and symptoms of internal bleeding, like bleeding gums or increase in bruises, blood in the stool or in the urine, and what to do. Know your INR and target range if you're taking Coumadin, and how often to have blood checked. Oxygen therapy. We should be teaching patients, if they are on home oxygen therapy, the dangers associated with oxygen use and the dangers of increasing their oxygen use more than the prescribed amount. Also, smoking cessation and any other health promotion subjects, like getting an annual flu vaccination, pneumonia vaccination, and developing a plan to stop smoking if they still do. This also goes along with weight reduction. And then report any weight gain. Usually a weight gain of 3 pounds in 2 days or 3 to 5 pounds in a week is something that should be reported to the healthcare provider immediately. Report any worsening symptoms of heart failure. So we need to teach them the signs and symptoms of worsening heart failure. And we can think of the acronym FACES, FACES, fatigue, limitation of activities, chest congestion, cough, edema, and shortness of breath. Have them recall the symptoms experienced when the illness began, and reappearance of those symptoms may indicate a recurrence of heart failure. They need to report immediately to the healthcare provider any difficulty breathing, especially with activity or when lying flat. We can teach them, if they are having problems breathing, they can elevate the head of the bed with pillows or rest in a recliner. Any frequent dry hacking cough, especially when lying down, needs to be reported. Any additional swelling of ankles, feet, or abdomen, or swelling of the face should be reported. And with rest, we need to teach patients to plan a regular daily rest and activity program. After exertions such as exercise and performing ADLs, to have them plan a rest period around those working hours. And avoid emotional upsets. Any worsening of concerns, fears, or any feelings of depression should be reported to the healthcare provider. And then their dietary concerns, decreasing their sodium intake, decreasing their fat intake. Weighing themselves at the same time each day, preferably in the morning, using the same scale each time. Maybe even eating small, frequent meals if they're having difficulty with breathing and eating. Thank you for joining in. This page shows the references that I've used for the presentation.